Hello, my name is Matt Thomas. I'm a consultant anaesthetist and intensivist at Bristol Royal Infirmary. I'm also the lead doctor with Great Western Air Ambulance and a member of the AIRWAYS-2 team. I'm going to talk you through the practical demonstration of intubation for the intubation arm. Before I start, just some things to make clear. This is clearly a mannequin and not actually a patient in cardiac arrest. So to make the demonstration clearer, we're going to take a few things as read. First of all, wherever possible, you should use universal precautions when approaching a cardiac arrest patient, in particular gloves, but we're not going to use that for this to allow you to see what I'm doing more clearly. In addition, the Resus Council recommends that chest compressions continue and that we minimise the amount of hands off the chest time. So we would recommend that you perform intubation while chest compressions are going, and if possible, pass the tube with chest compressions going, although they do allow a short pause at the time of placing the tube. But certainly laryngoscopy should be performed with chest compressions ongoing. Okay, so some of the equipment that we're going to use today. We've got a laryngoscope, and we would recommend using a Macintosh 4 laryngoscope, the larger one, wherever possible. We have a gum elastic bougie, and these should be available to every member of the AIRWAYS-2 team and those of you taking part in the trial. When you get a chance, this must be formed with a hockey stick at the end. If you find that it's straightened out, they are possible to bend and they do retain their shape. So ensure that it has that hockey shape look to it. The hockey shaped end is the end that goes in. An ET tube, something to bag the patient, something to detect whether or not they've got carbon dioxide. This is a colorimetric carbon dioxide detector. Now, wherever possible, we'd recommend that you use a waveform carbon dioxide detector because they're more accurate and they're what's recommended for the future. But we know that every ambulance service in this trial has access to colorimetric, so for the purposes of this, I'm going to show you that. But please, if you get a chance, use the waveform one. And a method of securing the tube. A good old-fashioned stethoscope to have a listen. Right, I'm going to make a start. Okay, so the first thing you should do, practical airway manoeuvres. Ensure the patient's in an optimum position. Wherever possible, the ears should be in line with the manubrium. Okay, and when you look into the airway, there's quite often soiling with blood or vomit. So the first thing you should do is to use a simple suction tube to remove any of that. Obviously not doing any blind suctioning. Take the laryngoscope. Take it in your left hand. I'm sure you're all aware it's a left-handed instrument. Now a couple of little tips from me. Hold the laryngoscope as low to the bottom as possible and try and have your focal length is usually between 12 and 18 centimetres depending on your age. So try and have your eyes about that far from the patient. As you're looking at it, we're going to call this the right hand side. So place the laryngoscope into the right hand side of the patient's mouth and then sweep the tongue over to the middle. You're looking for the epiglottis. So this is the view that you're attempting to obtain. The tip of the laryngoscope in the vallecula. Okay, so that's what you're looking for. Now, I must say I've intubated probably a couple of thousand people. I don't always get that view, and neither will you. So place it in, as I said, into the right hand side, sweep the tongue across. The key here is that it is a lifting and not a torquing motion, okay? So you need to be lifting away and not rocking back on the front teeth, because not only do you risk damaging the teeth, but perhaps more importantly, you get a far worse view doing that. Sometimes you can use your other hand to look in here. So moving it across, you can look up, and oh look, as if by magic I have the view in the picture. Grab your bougie, okay, ensuring that you're placing the hockey stick end in. This is where you need an assistant if at all possible. Placing the bougie in, you can hear it rattling across the cord, across the rings of the trachea. However, that's a good sign it's in place, but no guarantee. In the past, people have been taught to force them in until they hold up. Now that is a way of checking it's in the trachea, but it's also dangerous and risks you perforating the trachea and causing a pneumothorax. Now I've looked up at you for the purposes of demonstration. However, in reality, what you really want to do, and I'll do it again just to demonstrate, is you need to keep you need to keep that view of the cords at all times and make sure that you are constantly looking there until you've got it secured. So I'm going to get my assistant now to hand it to me when I get a decent view. So I've got a good view. So I say I've got the bougie. I'm going to place it over here in the rattle. He's going to place the tube over the top of the bougie. I'm going to continue looking. I'm going to say I have the tube.
I have the bougie.
And place it in. At this point, occasionally it holds up on the glottic opening. We can recommend a 90-degree tilt to get it through that. I'll place it into between 22 and 24 centimetres. Okay, can you withdraw it please? Okay, once I'm happy it's in, I can remove my laryngoscope and go to the next stage. Just to blow the cuff up. Okay, I'm going to place my colorimetric tube on there. I'm going to have a listen to the patient's chest. Can you squeeze for me? Okay, there's good air entry there, there's good air entry there. Okay. So, this is a mannequin without any beating heart, so it's not going to have any colour change on this. I'm going to demonstrate for you what it would look like. So in a person with a normal cardiac output, a CO2 will change the colour from purple to yellow. Unfortunately, in cardiac arrest, often patients don't have a normal cardiac output. Sometimes that colour change is affected. And we can give a demonstration of that by blowing air through it a couple of times. So if you notice here, the colour is more likely to be that browny colour, which is confirmation that CO2 has come through. I'm going to get a brand new one so that you can see the difference. Okay. So you can see no CO2, low CO2, no CO2, normal CO2. Okay, so the colour change just changes from that to one of the brown colours. Right. So we're happy that our tube is in. We've confirmed it with both capnography and by listening to the patients. You can then move towards post-cardiac arrest care, if that's the case, if the patient has gained circulation. If they haven't, you can now move towards continuous compressions. So once you've placed an endotracheal tube, one of the principal advantages in cardiac arrest is that we can now move to continuous CPR, as recommended by the Resus Council. You do, however, need to secure your tube. Now, every ambulance station has a Thomas tube holder, which disappointingly was neither invented nor is named after me. Otherwise I'd be doing something else on my big island. The key to it is to make sure you put it in the right way up. So in order to do that, make sure the Thomas can be read as if you were facing the patient. So it's got a small bite block in it. So place the bite block between the teeth, allowing the tube to sit in that natural groove there. And just quickly rotate that. And this leaves you with this section, which you can place underneath the patient's neck. It fits through here, like so. Alright, to go on like that. Quite often I see these plastic bits being left on, but it's incredibly easy to just unroll that, tie it on, and there you are, ready to continue. So I know that the vast majority of you will have intubated many dozens of patients. However, hopefully there's an opportunity to pick up some small tips and tricks from those of us who do it on a daily basis in hospitals. Some of the things that I'd like to focus on would be, we'd recommend the use of the larger Macintosh 4 wherever possible to ensure you've got an adequate view. I'd say holding the laryngoscope towards the bottom gives you a better ability to get a decent view, and try and keeping your face about 12 to 18 centimetres away. Occasionally you see people peering right down, which is very difficult to get a good view. Make sure that you use a lifting motion and not an angling motion, because not only does that risk damaging the teeth, but also risks getting a worse view. Perhaps the most important tip that I could give you would be to make sure that you use an intubating bougie wherever possible. Okay. As I said, I've worked in anaesthetics and ICU for 15 years, and this has got me out of an awful lot of tight situations. Now working regularly in pre-hospital care, I use this for every single pre-hospital intubation. So the intubating bougie is a really valuable bit of kit that I would not want to be without. Make sure you hold it into the hockey stick formation, and wherever possible get an assistant to help you place it. Do not preload it. The point of the bougie is that it can be used easily to direct into the larynx. If you put the tube on beforehand, what that does is it causes it to be weighted at one end and flip up like that. So the bougie should be used as a single piece of kit until it's inside the trachea. So hopefully there's some little tips for you to take away from this session. Please feel free to get in contact with the Airways team if there's anything else we can assist you with. Thank you very much for your time.